Okay, so here we are. We're going to finish up the respiratory system. And if you look at where we left off with the last one, we talked about the changes that happen with inspiration and expiration in terms of thoracic volume and pressure changes, and keeping in mind that those relationships, or that relationship between volume and pressure, is an inverse relationship. So we'll just kind of write that up here just to remind us that as volume of the thoracic cavity increases, the pressure is going to decrease. And then the opposite is true as well. So if we have a decrease in volume of the thoracic cavity, our pressure is going to increase. So what do we see here? This is basically just a graph that puts all of that information together in one place. And we've got our different pressures that we have already defined. So we've got our intrapulmonary pressure, which is going to be the pressure here inside the lung itself. We've got our intrapleural pressure, which is going to be our pressure here in this pleural space between the lung itself and the wall of the thoracic cavity, and the fact that we've got that difference between the two. It creates a negative suctioning type of force, and it holds the lungs out, expanded against the walls of the thoracic cavity. So what happens when we're breathing? What we see with inspiration, so when we breathe in, what's happening is the diaphragm is descending, our rib cage travels upwards and expands, so thoracic volume is increasing. So we have an increase in volume, which is going to correspond to a decrease in pressure. And that's exactly what we see. Here we're starting at our pressure at 0, which is basically going to be relative to atmospheric pressure, the same as atmospheric pressure, so we can just zero it out. And we take that breath in. What happens to our pressure? It basically falls down into the negative as we breathe in. That's going to pull air in because air is going to flow down its pressure gradient. And at that point, it's at a higher pressure in the atmosphere around us than in our lungs. So air is going to flow into our lungs. Okay, and then we can drop down. We always have this difference here between intrapulmonary pressure and intrapleural pressure. So it's always going to be about 4 millimeters of mercury difference between those two. Okay, and then what happens when we expire? So this part of the graph is showing you expiration. So in expiration, our diaphragm is going to return back to its resting position, and rib cage moves downwards. So in all of those changes, the volume of our thoracic cavity is going to decrease. So we're going to have a decrease in volume. Sorry, my mouse is so touchy. Okay. I promise it'll get better. In expiration, our volume is going to decrease because the thoracic volume is getting smaller, and we know that that corresponds to an increase in pressure in our lungs. And so what happens here, as we're expiring, our pressure is going to increase above atmospheric pressure. So here we're above that 0 line, right? And pressure in our lungs increases above that of the atmosphere around us. Air is going to move down its concentration gradient, so then air flows from our lungs, from that area of higher pressure, out into the atmosphere, and we expire it. Again, we have the same thing here, where our intrapleural pressure is going to be basically just a line that's dropped below this intrapulmonary pressure. And we've got that difference. And that difference there, as we defined it previously, is our transpulmonary pressure. So the difference between the two. And so this is what happens. And then as we're breathing, this is showing you basically like, one breath when we move air in and out. So what's happening here is that as we create those pressure changes, we're basically moving air in. We breathe in about a half a liter of air, and then with expiration, we're going to breathe it right back out again. And so this is kind of one breath in and out, and this is showing you here too. This is volume of breath, which is showing you here this 0.5 liters or 500 milliliters of air that we move in and out of the lungs with one breath. And we actually have a name for that. We call that our tidal volume. And that's important, and you do need to know that. So tidal volume is the amount of air that we move in and out with one breath. And at rest, you can say that it's 500 milliliters. Okay, so here we are with airway resistance. Just some of this stuff is just kind of a little bit of a reminder, tying it into things before. If you'll notice, look at this guy right here. That looks really familiar, right? It should. It's the same that same relationships that we saw with blood vessels and blood flow. So it's the exact same thing. So basically flow is going to be airflow. Change in pressure is that pressure gradient that we see between the atmosphere around us and our lungs and our alveoli. And then resistance is resistance to airflow, which is what we see when we change. Here's resistance over here. When we change size of our bronchi and bronchioles as they get smaller, our resistance is going to change. So that's going to play a role too. So I just wanted to, I included this, I wanted to remind you here, it's basically the same thing as blood flow when we were doing cardiovascular system. And just by way of reminder, because that resistance is on the bottom, airflow here is going to vary inversely with resistance. So as resistance increases, our airflow is going to decrease. And we're going to see that. You'll be able to work with that a little bit in lab. We're hoping this week when we have patients who have like asthma and that sort of thing, when their airways constrict, it's going to decrease airflow. So that's where that plays a role. So that looks familiar. These are basically some respiratory volumes and capacities that we see. And this is important, especially if you do like pulmonary function testing. If any of you guys have had asthma and you've done like a spirometry test, this is one of the things that they're looking at. But what's important here? So there's a lot of information. And honestly, I don't really necessarily want you to know numbers. The only number that I think you really should know is this tidal volume being 500 milliliters. And that's basically that, amount of air that you can pull in and out with each breath. So if we just hook someone up to a spirometer and they were just breathing in and out normally, this is what we would see, that inhalation, exhalation, inhalation, and that would be tidal volume at 500 milliliters. So what happens if we have our patient breathing in and out and then we say, okay, take a big breath in, breathe in as much as you can. That's going to look like this on our tracing. They're inhaling as much as they can, and then they exhale that. That is an important volume. That is called our inspiratory reserve volume. So inspiratory meaning you're inspiring, and how much air can you possibly pull in if you were going to suck in a lot of air. That's what that is. Now, on the flip side of that, you can ask your patient to blow out as much air as you possibly can. So we're going to follow this curve, and it's going to go down, and it's going to blow out as much air as we possibly can, right down to the bottom there. And we're going to call that our expiratory reserve volume. Okay, so how much air can you possibly blow out if you're blowing out as fast and as hard as you can? Okay, so we can take all of these and basically add them together and create these capacities. So like our inspiratory capacity is going to be our tidal volume plus our inspiratory reserve volume. It's how much air can you move in at any point in time? What's the capacity of your inspiration? And then vital capacity is going to be inspiratory reserve plus tidal volume plus your expiratory reserve. So it's basically, all of this, how much air can you possibly move in and out of your lungs with these big breaths in and these big breaths out? That's your vital capacity. And that's basically how much air do you have access to. We can also look at this number here. I think this is kind of interesting. This is your residual volume. And so if you think about what that means, residual volume is basically the amount of air left in your lungs at any point in time. You can't get it all out. There's always a little bit of air that's left in your lungs, and that's residual volume. Okay, so again, I don't get too hung up on the numbers here. I mean, this is kind of nice because we have descriptors here. So I would expect you to be able to work with this. Again, what I would probably do is take these images and put them into your Google site and write down some notes to be able to answer some questions about it. I'm more interested in you being able to use it. So let's say, for example, like an example question would be, you have a patient in your clinic and you ask them to take the biggest breath in that they can. What lung volume are you measuring? So that would be inspiratory reserve volume. They take in the biggest breath that they can. Okay, and there's also a video posted about this on Moodle, so I'll make sure I point that out. Couple other things here, anatomical dead space, and I include this because this basically highlights this whole conducting zone area of our respiratory tract. Remember how our respiratory tract was divided into two different zones? We had the conducting zone, which is just responsible for conducting air. There's no gas exchange that's occurring there. And then we had our respiratory zone, which is down a little further. And that's where we actually have gas exchange occurring, respiration. So in this conducting zone, we have air that basically gets trapped, up here in some of these larger airways, and it does not contribute to gas exchange because it's in the conducting zone. So with each breath that you take, there's about 150 milliliters of that air that doesn't do anything for you. It's called anatomical dead space. It's just air that doesn't contribute to gas exchange, and it's just hanging out. And then with the next breath, you end up breathing that out and then breathing some more in. So out of a typical 500 milliliter breath in and out, which is our tidal volume, about 150 milliliters of that is going to be dead air. It doesn't do anything for us. So if we actually wanted to tease out, okay, how much air contributes to gas exchange, we could actually subtract the two. So we could say 500 minus that 150 that we know does not play a role in gas exchange is going to give us 350, right? So 350 milliliters per breath contributes to gas exchange. Okay, so we could actually tease it out and make it a little more specific. And that's what we see when we look at this. So we can actually calculate both minute ventilation, which is basically the amount of air that we move in and out of our respiratory tract every minute. So if we look at minute ventilation equaling milliliters per breath, which is basically our tidal volume, right, at rest, times breaths per minute, okay, that would be our units there. And so what's going to happen with this is that our breaths are going to cancel out, and we're going to be left with milliliters per minute, or we could actually then just, change that to liters per minute. However you want to look at it is fine. But if we say, okay, milliliters per breath is typically about 500 milliliters per breath, and breaths per minute, what's a typical respiratory rate for a patient? Typically anywhere from 12 to 20 breaths per minute is what we normally see. So if we had, I'm going to pull up my calculator here. Let's say that we had a patient coming in and they were taking 500 milliliter breaths and they had a respiratory rate of 16. So we would say 500 times 16 equals 8,000 milliliters per minute, or 8 liters per minute. That would be their minute ventilation. Okay, so I gave you a couple numbers here. Typically, minute ventilation is around 6 liters per minute at rest, but it can certainly increase much more than that when we exercise. So it can go up to 200 liters per minute or even more, because as we exercise, what happens, we're going to increase our volume with each breath. You're going to suck in a lot more air, so that 500 is going to go up. And then we're also going to breathe faster, right? So our breaths per minute is going to increase as well. Now we can actually get a little more specific with this, and we can tease out our alveolar ventilation rate. And this is the same thing, except we are just taking into account that dead space. Okay, so we still have breaths per minute, and we're still calculating milliliters per breath, but what we're doing is we're actually subtracting out that dead space, just like we did before. So if I back up one, it would be using the calculation with this number, with that 350 instead of 500. Okay, so alveolar ventilation rate is going to be, or flow, alveolar ventilation is going to be a little bit less, because we're subtracting out that dead space, and because we're getting rid of all the air that doesn't contribute to gas exchange anyway. So just realizing it's a little more specific because we're taking away that 150 milliliters per breath of anatomical dead space. Okay. All right. So the process of external respiration, if you go back to those 4 processes that contribute to the respiratory mechanism that we have, we've got 3 different factors. We've got partial pressures, which we're getting ready to talk about. We've got respiratory membrane, which we've talked a little bit about, between the alveoli and the capillaries that surround them. And then we've got this idea of ventilation and perfusion, which is the fact that our body is able to match breathing and blood flow. Perfusion is blood flow, and we want a good match so that we can fully move oxygen from our respiratory tract into our cardiovascular system. Okay, so we're going to talk about a few of these. Honestly, right now, I think I'm going to move through this and go ahead and talk to you about partial pressures of gas. And what I've done here is I've given you partial pressures. If you look on this side of the table, we've got, this is the atmosphere. So this is what we see. So here's oxygen. Oxygen comprises 21% of our atmosphere. So 21% of the air around you is oxygen, which gives it a partial pressure of 160, and this would be millimeters of mercury, which is the units for pressure. On the flip side, carbon dioxide accounts for much less. In the atmosphere, it's down at about 0.04%, which gives it a partial pressure of 0.3. Okay, this is what we're going to be working with here, these partial pressures, and I'm going to show you how this relates. We breathe air in, and it travels down to our alveoli. What we see at that point is oxygen is in a lower concentration at 14%, and its partial pressure is at 104. It's now gone down to 104. And that's because it's mixed with carbon dioxide that's leaving, and we have a lower percentage of oxygen at that point. Carbon dioxide has done, so we'll say basically a decrease in oxygen content when we get down to the alveoli. Okay, it's gone down. Let's look and see what happens to carbon dioxide as we travel to the alveoli. Carbon dioxide has now increased in concentration, so it now accounts for 5% of the air down there, and its partial pressure has increased to 40. So our carbon dioxide has actually increased because we're actually going to be expiring it from our body. So that's what we see. So how does this tie in? And this is how we see it as a whole. Okay, here's our inspired air here. And here's our partial pressure of oxygen at 160 and our partial pressure of carbon dioxide at 0.3. Okay, that's the air that we're breathing in. As we travel into the lungs, we pull that air into the lungs, and that new air is going to mix with old air, and it changes the partial pressure of oxygen and carbon dioxide. So we see our oxygen content just went down, so our partial pressure of oxygen went down to 104. Our partial pressure of carbon dioxide just went up to 40 because they're mixing. Okay, so blood leaves the lungs. Okay, here's our lungs. Blood's going to leave the lungs and travel out to the body. Okay, it returns to the left atrium, left ventricle, and it gets pumped out through the aorta, and it's going to travel to the body's tissues. Blood leaving the lungs, this is going to be this is arterial. On the arterial side of things, okay, we see some changes in our partial pressure here. Now, really the only difference is that the partial pressure of oxygen has decreased from 104 down to 100. We've lost a little bit of oxygen, and that's just because the bronchial arteries and pulmonary circulation kind of mixes a little bit, and so the arterial blood mixes with some venous blood, and it actually brings the oxygen content down a little bit. That's kind of details at this point. So the main thing here is to know that partial pressure of oxygen in the artery is at 100. Partial pressure of carbon dioxide in the artery is at 40. Okay, and we travel down to the tissues, right? And so we're going to have these capillary beds that are going to feed tissues in the body with oxygen and carbon dioxide. So what do we see here? What's happening at the tissues? In the tissues, we have a lower partial pressure of oxygen. It's down to 40. So look, if we at this point have a partial pressure of 100 in the blood, partial pressure of oxygen is at 100. In the tissue, partial pressure of oxygen is at 40. Oxygen is going to diffuse down its concentration gradient, or down its partial pressure gradient. Okay, so that enables oxygen to diffuse from the bloodstream into the tissues, and that's exactly what happens. Okay. On the flip side of things, if you look at the partial pressure of carbon dioxide, it's in the tissues, it's more than 45 millimeters of mercury. In the arterial bloodstream, in the capillary bed here, it is less than that. It's at 40. And so carbon dioxide is going to move from the tissues into the blood vessels down its concentration gradient. It just went from 45 in the tissues to 40 here in the capillaries. Okay, so it's going to move from tissues into the bloodstream. And so as we come out the other side of it, this is what we see, blood leaving, and now we're on the venous side of things. So this is going to be in the veins. What we see is partial pressure of oxygen has gone down to 40 because that's what we see here. So oxygen has diffused from from the blood vessels into the tissues, and it's brought that oxygen content down to 40 millimeters of mercury. Carbon dioxide has actually increased to 45 millimeters of mercury, and that's what we see here. And we return to the lungs. And so if you look at what we have at the lungs, because of these pressure gradients, we're going to end up moving carbon dioxide down its pressure gradient, right? We're going from 45 to 0.3. Carbon dioxide is in a higher gradient inside the lungs than outside, so carbon dioxide is going to be expired, and the opposite happens with oxygen. Oxygen is going to be inspired at the lungs. So that's all, that's the ability of these partial pressure gradients to be able to move oxygen and carbon dioxide, because they're moving, as a reminder, by diffusion, right? So we need those gradients to be able to make sure that that happens. Okay. Our second factor that affects respiration is our respiratory membrane. And if you recall, that was that 3-layer membrane. We had the wall of the alveoli, we had the fused basement membrane together, and then we had the wall of the capillary, and all very thin and allowing for that diffusion of oxygen and carbon dioxide across it. So also note too that respiratory membrane has a huge surface area, because we've got all those tiny little alveoli that are put together like this. Much greater surface area like that than if we had just one huge alveoli. So that contributes as well. And just briefly, this ventilation perfusion, so meaning that the rate of ventilation, so air moving in and out of the alveoli, and the rate of perfusion, which is going to be blood flow through those pulmonary capillaries that surround the alveoli, needs to match so that we have a good mix of both. Okay, this is the kind of the final process of respiration, and this is internal respiration. So this is basically what's happening at our tissue level, and this is kind of a close-up of what we just talked about here. This right here is showing you internal respiration as well, but if we look at it on this image, what we see here is still relying on partial pressure differences between the two, but at this point we're now down to the tissue level. We've got oxygen content in the capillaries that's much higher than in the cells, so that's going to drive oxygen into the cells by diffusion. And on the flip side, we have a much higher carbon dioxide concentration in the cell than in the capillary, so carbon dioxide is going to diffuse down its gradient into the capillary. Okay, the opposite of that is happening here with this external respiration, which is occurring in the lungs itself. We have the opposite process. Okay, how is oxygen and carbon dioxide transported in the blood? Most oxygen is actually bound to hemoglobin. Okay, and we know this. We talked about this in blood, so we call that oxyhemoglobin. It binds to the heme group, and if all 4 heme groups in a molecule of hemoglobin are bound, then we call that hemoglobin fully saturated, and that's typically what we see. Okay, let's get through dissociation curve. In terms of oxygen and hemoglobin dissociation. So what we see here is dissociation curves basically explain how hemoglobin loads and unloads oxygen. Okay, because not only do we have oxygen bound to hemoglobin, we still have a little bit of oxygen that's actually just dissolved in the plasma of our blood, just a little bit. So blood contains oxygen attached to both hemoglobin and dissolved in the plasma as well. And our PO2 is the measurement of how much oxygen is actually dissolved in the plasma, okay? As opposed to just, it's basically how much oxygen is available in the bloodstream for our body to use. So what we have is this concept of affinity. So how much does hemoglobin want to hold on to its oxygen, okay? And there are several conditions where we can have a decrease in affinity for oxygen. One of them is increased temperature. One of them is increased levels of carbon dioxide. And one of them is a decrease in pH of our bloodstream. So if our blood becomes more acidic, all of those factors will result in a decreased affinity of hemoglobin for oxygen. So when do these things happen? When do we have all of these conditions? Mainly when we have increased metabolic activity, such as during exercise. Okay, that's when we see this. So when we are busy exercising, the temperature in our muscles goes up, the amount of carbon dioxide goes up because we are releasing it as a metabolic byproduct, and our acidity is going to increase, creating a decrease in our blood pH. It's going to become more acidic, okay? In all three of those conditions, what we end up seeing is a decreased affinity for oxygen and hemoglobin, okay? What that means is that hemoglobin is going to unload that oxygen from the bloodstream into the tissues, which that's exactly what we want to have happen. We want the oxygen to be in our tissues. We don't want the oxygen to be trapped in the hemoglobin in our bloodstream. Okay, so that's what we see, and we call this type of curve is called an oxygen hemoglobin dissociation curve. Okay, which is basically, this is our pressure of oxygen, partial pressure of oxygen, and this is our percent saturation of hemoglobin on this side. And this is the same, they didn't write your partial pressure of oxygen here, but this is basically the same, okay, at partial pressure of oxygen. So let's take a look and see what happens. This is our normal curve. So if we look at this one here, this is our normal curve, okay? And then also here, this is our normal curve for both of these, okay? And so what we see is that we end up having a right shift, okay? In that oxygen hemoglobin dissociation curve, we end up with a right shift with increased temperature, increased carbon dioxide, and decreased pH, which is all of the changes that we see with exercise. Okay, so here's our right shift. So if we increase our body temperature, okay, we have taken this whole curve and we've moved it to the right. Okay, and if you look at this one, here's our levels of carbon dioxide. Again, on this one, we've moved it to the right of the normal curve. Okay, so what does that mean? That means at the level of the tissue, so let's say a partial pressure of oxygen of 40. So we're going to be about, where, 1, 2, 3, 4. Yep, 1, 2, 3, 4. So about here, okay, where normally the percent hemoglobin saturation at that level would be about 70. What we see is at that same partial pressure with a higher body temperature, we now have a percentage of hemoglobin that's saturated that's closer to about 50% saturation, right? So it just went down from 70% to 50%. Where did that oxygen go? Where did that 20% of oxygen go? Well, it was unloaded because of decreased affinity, and it's now in the tissues, which is exactly where we want it to be. We want it to be in the tissue so that we can use it, right? And then let's look at this one. Same thing here with increased carbon dioxide. So let's say at a partial pressure of 40, we're sitting here, about 75% of our hemoglobin is saturated. Let's look on this curve. If we follow that partial pressure line up, and we're here, right? That's where this curve crosses. It's more like 60. So we just went from 75% of our hemoglobin being saturated down to 60% of our hemoglobin being saturated. What happened to that 15%? It got unloaded into the tissues, right? So that's a good thing. We like that, and that shift happens for a reason, so that when our tissues are working, hemoglobin has less affinity for oxygen, and it says, here you go, take it, because you need it worse than I do, right? So yeah, oxygen hemoglobin. Okay, last thing that we're going to talk about here is how is carbon dioxide transported in the blood. So a couple different ways. Most carbon dioxide, 70% of carbon dioxide is transported as bicarb in the plasma. Okay, so that's what we see here. So basically, when carbon dioxide enters the bloodstream, it's going to combine with water and it's going to form carbonic acid. Okay, so these two combine to form H2CO3, which is carbonic acid. Carbonic acid pretty much immediately dissociates into bicarb, which is HCO3, and a hydrogen ion. Okay, so this is the way most of your carbon dioxide is transported in the blood as bicarb. About 20% of our carbon dioxide is transported as attaching to an amino acid group of hemoglobin. Again, it doesn't compete with the heme group. It doesn't compete with oxygen. It has its own attachment site, which is to amino acids in hemoglobin. And then just a tiny little bit of carbon dioxide is dissolved in the plasma. Okay, so that's carbon dioxide. And then the last thing that I want to mention here, and I think this is going to wrap up our respiratory system, is I just want you to know big picture. How is breathing controlled? How does our body control rate of respiration, like how frequently we breathe and how deep we breathe? And we do that through the medulla. Okay, and if you recall, this should kind of make sense because the medulla also controls heart rate, because we have the cardioacceleratory, cardioinhibitory centers in the medulla, and we also have the vasomotor centers in the medulla, which are going to control vasoconstriction, vasodilation. This is just another, base bodily function that's controlled by the medulla. So just add that to it. I don't think we're going to worry too much about the respiratory groups. Let's just keep it big picture. Breathing's controlled in the medulla. And I think we'll probably wrap up respiratory system with that. Okay.